Hiya. Uh, this is just a very quick presentation, hopefully should take less than 5 minutes, about the reintroduction of the A2B study that we're about to start again. So you might remember A2B is a sedation study that we were part of before COVID happened. This is a very quick introduction, and there will be some more learning that we'll all need to do again, unfortunately. So you'll remember that it's a trial of 3 sedation regimes. So propofol and opiate, which is just our standard regime, clonidine with opiate, and dexmedetomidine and opiate. Now, all of these can have additional sedation, and it's not infrequent. About 40% of the time, the study kind of groups 2 and 3 also have propofol running. But in those study groups, it's important to remember that if you're going to reduce something first, it should be the additional sedation over and above the study arm. So the clonidine or the Dextor. What the study's looking at, the primary outcome is time to extubation for each sedation regime. So does a different sedation regime mean that people spend less time on ventilators? That's one of the key questions. We'll also look, the study also is looking at duration of ICU stay and outcomes related to sedation, particularly delirium. And there's a lot more about that in the educational packages. And then there's a sort of a secondary analysis going on, looking at whether dexmedetomidine is a cost-effective drug for the National Health Service, or whether clonidine is just as good for reduced cost. So a successful extubation is when it's been deemed as a patient being without a ventilator for 48 hours. So once we extubate, 48 hours later, if they remain extubated and off sedation, off ventilation, that will be considered a successful extubation. Now, they've included tracheostomy patients as well, and a success in a tracheostomy patient is when they've been on 5 of PEEP and 5 of pressure support for 48 hours. So obviously our practice, it's not infrequent that we rest patients overnight. So that's something that we would potentially have to consider when we're kind of weaning A2B patients on trachees, but we shouldn't deviate from our standard practice too much. So the population, it's a pretty wide study. So basically adults over 18 who are ventilated and expected to be on a ventilator for at least 48 hours. Now we've got 48 hours to recruit, 48 hours from the initiation of ventilation to recruit them. So it's actually quite an easy study to get involved in. And the trial has restarted for a while. They're kind of re-getting centres back up and running, and we're one of the centres that they're about to start going again. Obviously there are some exclusions, and the exclusions are mainly patients who might be on a ventilator for a long time for a reason other than sedation. So brain injured patients are excluded. People with status epilepticus are excluded. The neuromuscular diseases, so myasthenia gravis or GBS, they're not included. Patients who have fulminant hepatic failure, and obviously patients who the feeling is they may have less than 24 hours to live, or in fact they're palliative. Now, because dexmedetomidine can cause bradycardia, anyone with an untreated type 2 or type 3 degree heart block is excluded. But if it's treated, for example, with a pacing wire, then they would be okay. And similarly, patients who have hypoxic brain injuries, they're cautious about recruiting patients who have had cardiac arrest in the community. Now, that's not to say we wouldn't recruit them, but if after they come in, we assess them and they look like they might be neurologically intact, but they remain intubated, for example, because they've got a pneumonia, that patient would be eligible for inclusion. Interestingly, prisoners are excluded, and also you only get one go at this. So if you've been previously enrolled in a trial, you can't be enrolled again. So the bedside staff are key to this study because it's important that we follow the sedation protocols. And a fundamental part of the sedation protocols are assessing the sedation, so doing the Ramsey assessment of sedation score, so the RASS score, and both setting a sedation score that we're aiming for and assessing that sedation score. So that's absolutely crucial. So if nothing else about our involvement in this trial, it will ensure that we administer sedation according to kind of best practice guidance. So retraining, everyone would have done the training before, but there will be new staff, both medical and nursing staff. So the expectation is everybody will kind of complete the training again, which isn't too long, but you will kind of have to find a little bit of time in your week to do it. So shortly, I will email a slide set which you can go through, and there will be a link to a kind of LearnPro online learning platform. Now, it's not too arduous to do it, but if we're going to recruit our target of 2 patients a month, it will need everyone to be involved. So there's one module to do for the nursing staff, and the medical staff actually have 2 modules to complete. So thanks for listening, and we're hoping to get going towards the end of September, but we can't get going until the great majority of us have recompleted the online learning. So thanks very much. Thanks for your help, and any questions, ask either Maria Faulkner